This is the case of 77 years old female. Yes, she has IPMN diagnosed in 2010. The patient has two cysts, one of 20 millimeters in the head of the pancreas and the other one of 15 millimeter in the tail. She has normal main pancreatic duct, and last February an MRI showed that the cyst of the tail increased in size. So the patient is here today for US evaluation with Sonoview and FNE.
Well, first of all, I would like to thank Mark for inviting me. It's a great pleasure and privilege to be working here and to be with my colleague Nick, who is going to be helping me in this case. You heard the story. This elderly lady has two cysts, and she's been diagnosed with IPMN, the side branch type, which is, or they used to be called the branch duct type. And from my understanding, she was followed since years, 2010. And there has been an increase in the size of the cyst in the tail, but unchanged in the size of the cyst in the head of the pancreas. So now I'm using the SLIM linear echo endoscope by Pentax. And as Paolo mentioned, it's a very nice imaging you can get, although it might be a little bit hard to control it because it's a little bit floppy. But all in all, the performance is excellent. And I'm looking now at the lesion in the head of the pancreas. My probe, the tip is in the duodenal bulb at the level of the apex. And if you look at the screen, you'll see this lesion here. Can we put the Doppler and the flow Doppler, please, on it? You can see this lesion, and there is a septum, which appeared to me a little bit thick in the middle. This is the lesion that is in the head of the pancreas. Later on, I'll show you the one in the tail. The one in the tail looks very different. It looks unilocular. It looks about hardly 2 centimeters in size, very thin wall, without any nodules. And I'm going to show you this ultimately. But this one looks a little bit more suspicious. Although by MRI, it hasn't really increased in size. I'm not sure if an EUS was done, when was the last one it was done. But we're going to just take a good look at it, make sure there are no nodules, no solid component. We'll do the same for the tail of the pancreas lesion, and then we'll probably do a sonoview exam. The question initially was whether we need to perform the sonoview exam on the tail, but I think if we have to do it, probably this is the lesion that we have. You agree, Nick?
Yeah.
All right. So before we proceed, any questions from the audience? All right. So we're looking here at the lesion again, and let me just, can you please change the frequency? I'll get a better view at the lesion.
Reduce the frequency to 5.
Yes. Okay. I can see the septum.
One thing that is very important to highlight in the follow-up of any kind of IPMN is that you don't only need to focus on the cystic lesions, but there is an increased risk over time to develop solid lesions. So whenever you do the follow-up of any kind of IPMN, please take a look at the complete pancreas, because you may find some additional solid lesions that may be high risk for adenocarcinoma.
Yeah. The main duct, the main pancreatic duct appears normal. There is absolutely no dilatation, and we show that it's really separate from these lesions. So we're going to start by doing the sonoview examination on this lesion.
Thank you.
Sonoview.
No. Wait.
Ah, yes. Okay.
Thank you.
It's not my machine.
I know. I was. So you got contrast. So it's this one here.
Inject the Sonoview. Attends. Wait.
So you want to have the B mode.
Wait. Not yet. You want to change the easier? It's okay.
Yeah, it's fine.
Perfect.
Okay, everybody happy?
You can inject.
Okay, inject, please.
Okay, so we'll start the clock. We're injecting. So we're now in the arterial phase.
This is a bigger cyst.
So we've just started 10 seconds now. Seeing some vessels appearing. And you're looking at this area that's to stay on the cyst here. This is nodule. The nodule is here. And there is just a little bit of enhancement on the edge there.
Okay, now we're in the venous phase. Okay, so we can see that there is, at least in the middle, there appears to be some abnormal uptake or enhancement at the level of the septum. I'm not sure if this is a nodule or no. It doesn't appear to me like a classic nodule, but it's something that is a little bit hyper-enhancing. Okay, I think this is good.
This is hyper-enhancing.
All of you saw that?
Silence.
So what's your feeling, Nick?
I think this is genuine. I think this is a genuine concern. I'm a little bit concerned that there may be, and I think this is what Julio was referring to, there might be an unenhancing area here, which is worrying me more between the two cysts. And I'm worried that there is actually a lesion here.
Okay.
So if we did do a biopsy here, I would be more interested in aiming for this area.
Okay.
Because you can see the rest of the normal pancreas is enhancing very nicely. Here is the cyst. This is the nodule we're worried about, which we say is not really a nodule. But this is an area of pancreas which is not enhancing. And for me, on the original B image here, it's a bit darker because we're on the contrast study, but you can see there's an area here of lower echogenicity.
Okay.
So in my opinion, I think there's an area of concern. I don't know, Julio, whether you agree or not.
So
Is
basically,
some artifact from the septum?
No, I don't. It's genuinely a larger mass because it extends beyond the septum in that area.
if we go back to the consensus criteria, the Japanese or international and the European, the worrisome, these findings are a little bit worrisome because we do have possibly a nodules. There is some enhancement in the septum, possibly some lesion, which I'm not totally convinced there is, but possibly a lesion, while these findings do not exist in the tail of the pancreas lesion. So I think if we have to do a biopsy, we'll have to go to this lesion and access. So let's give the antibiotics,
5
please.
gauge. What do you want? 22, 25?
22, echo 3, 22.
22 or 20, it doesn't
Okay.
matter really. In the meantime, before we do that, I'll go back to the
antibiotic,
stomach
yeah.
and I'll show you the lesion that is in the tail of the pancreas.
But there's been a very nice demonstration that there is a big role of contrast enhancement in these kind of lesions because you can highlight some areas that is a very good to direct where to make the FNA.
Exactly.
It remains to be shown whether that's actually.
Yeah, but it's the area of interest between the two cysts. This is much more simple cyst,
This
isn't
is,
it?
can you highlight this?
Yeah. So I'll just
Okay.
increase the size.
This is the other lesion. Can you put the Doppler on it, please?
Yeah.
You have the needle is ready, if you
Yeah,
want.
just move it there.
It's further out. It's further out. It's up here. Further.
Here it is.
Just up here. It's right here. That's it. Okay. The lesion.
Okay, this is the other lesion. As you can see, can we please measure it, Nick? Freeze first.
Yes.
Okay. As you can see, it looks different from the other one. This is pretty much an elliptoid shaped. It looks without any nodule, and we can see the pancreatic duct, the main, next to it appears normal. It's hardly 2 centimeters. So I think if we have to target something, we'll target the lesion in the back, in the head of the pancreas. If this was the only lesion, I will definitely follow it. It is less than 3 centimeters. There are no nodules, no wall abnormalities. The PD is fine. So it doesn't meet the consensus criteria for worrisome or high suspicion lesion. So again, I hope everybody agrees with me on this. This is the lesion that I'm not worried about. I'm going to go back to the head of the pancreas and biopsy the lesion, try to target the septum and the area that is below it. So basically, can you torque a little bit? We're just going to just go straight. And
Down. That's it. In there. Go on in there. Go on in there. In between the two. That's perfect.
Yeah.
Perfect.
All right, can you put it, take it out, please? Yeah. Lift. Yeah.
Oh, I was going to do it.
Yes. Adjust the suction, please. Suction. Yeah. Nick, can you torque the scope for me so I can do the show people what I'm doing? Just torque it a little bit. Yes. Yeah, this is the area exactly.
Exactly where you want to be.
Yes. Here.
Yeah.
What
You
we're
are
doing
in
now,
a very
we're
good
trying
position,
to access the septum and the area under the septum. As you can see, this is very floppy. So we're trying basically to just get this area. And I think we're just getting it here. And we're moving very slow. I'm using the suction technique. I'm not much interested in the fluid, although probably I'm going to get some fluid. But I'm trying to access the area that we saw was abnormal, we thought was abnormal on the sonoview examination. So this is, again, the septum and the area below the septum. I think we're beginning to get some of the cyst fluid aspirate here. See? So we're just getting the septum, Mark.
Because
Okay?
we will go.
Okay, there you are.
So what needle are you using for the puncture?
I'm using the 22. Using the 22 gauge, and the reason I didn't use the 25 is that because if there is some fluid, it's mucinous. I don't want to use the 19, so 22 should be fine. I'm using the negative suction minus 10. Although for biopsies there are some data not related to this case of even using higher negative pressures of 60. There was one study on that. In this case, it's cyst and it's a septum. I think this is enough. Can we please stop the stopcock? And we will just, it's a single pass. And we'll close the lock and come out. Any questions from the audience?
I haven't got sound.
Very interesting case.
So this is the area that we accessed pretty much here and this here. Although I really don't think there is a solid lesion. I think this is just an artifact, but again, it might be. So this is accessed and this area is accessed, and we did a single pass. We'll see what we have.
Okay.
And that's it, pretty much.
Okay, thank you.
All right, thank
Did you
you.
give this person antibiotics?
Yes, she did get antibiotics before we started, definitely. Cystic lesions, we tried to do one pass and antibiotics, and that's what she got. She got antibiotics before the procedure.
Okay, perfect.
All right.